Welcome to the MI Mental Podcast. My name is Dr. Sabine Fonderson, and in this podcast, we'll explore real life cases from the intersection of mental health, medicine, and legal accountability. Today, we're diving into another gripping episode of our Doctors in Court edition, where we take a close look at a disciplinary case involving a maxillofacial surgeon. The case raises significant questions about professional responsibility, communication, and patient care following a dental extraction that led to severe complications. As always, I'll be using fictional names to protect the identities of those involved, though the details of the case are real. And over the next few minutes, I'll walk through the timeline of events, the plaintiff's accusations, the surgeon's defense, and the final ruling of the disciplinary board. I'll also break down some key medical terms and end up with two questions for reflection. Let's get started. Let's begin by walking through the key timeline of this case. December 2nd, 1999. Our patient John had a tooth extracted by a general dentist, and 2 days later, John experienced severe pain and swelling in his lower jaw and sought emergency care at the local hospital. December 4th, 1999. John was referred to the maxillofacial surgeon who we'll call Dr. Andrew, and he diagnosed John with a floor of mouth abscess. Dr. Andrew performed an incision to drain the abscess and prescribed antibiotics, specifically amoxicillin. John was admitted to the hospital for monitoring. December 6, 1999. Dr. Andrew, along with a colleague, decided to perform a second incision from the outside of the jaw to ensure all areas of the infection were addressed. A sample of the pus was taken for a bacterial culture, and another drain was placed to remove any remaining abscess. December 9, 1999. Dr. Andrew left for a medical conference, handing John's care over to another surgeon. At the time of his departure, John appeared stable and his infection seemed to be improving. December 18, 1999. Despite the interventions, John's condition worsened and he was transferred to a different hospital where he passed away due to complications from the infection. John's family, devastated by his death, filed a complaint against Dr. Andrew, accusing him of negligence and improper care. Let's now explore the claims made by John's family. John's family, represented by his mother and brother, brought forward several accusations against Dr. Andrew. Number 1. Failure to conduct a full physical examination. The family argued that when John was first admitted with the abscess, Dr. Andrew failed to conduct a comprehensive physical examination. They believe that more thorough diagnostics, such as blood tests or imaging, should have been ordered to assess the extent of the infection beyond the oral cavity. Number 2. Inappropriate use of antibiotics. The plaintiffs claimed that the prescription of amoxicillin was inappropriate given the severity of John's infection. They argued that a more aggressive antibiotic regimen should have been initiated earlier, particularly given the risk of the infection spreading to critical areas such as the neck and the chest. Number 3. Inadequate post-surgical care and communication. The family also accused Dr. Andrew of failing to provide adequate post-surgical care. They claimed that the communication between Dr. Andrew and the nursing staff was insufficient, which led to poor monitoring of John's condition. They argued that Dr. Andrew should have been more involved in John's care even after leaving for the conference. Number 4. Failure to escalate treatment. Finally, the family argued that Dr. Andrew did not escalate John's treatment when it became clear that the initial interventions weren't enough. They believed that he should have consulted with other specialists, such as an infectious disease expert or intensivist, to manage the worsening infection. These 4 accusations were the core of the plaintiff's case against Dr. Andrew, as they sought justice for what they believed was avoidable negligence. Now let's turn to Dr. Andrew's defense. Regarding the physical examination, Dr. Andrew acknowledged that he did not order additional blood tests or imaging immediately after John was admitted. However, he argued that the clinical signs indicated a localized oral infection and his initial treatment plan was appropriate based on the diagnosis of an abscess. He explained that the incision and drainage procedure combined with antibiotics was the standard treatment for this type of infection. Dr. Andrew emphasized that at the time, there were no clear signs of a deeper infection that would have warranted more extensive diagnostics. Appropriate antibiotic use. The surgeon defended his choice of antibiotics, stating that amoxicillin was in line with the hospital's protocol for treating oral infections. He explained that the bacterial culture results were pending, and the decision to use amoxicillin was based on the most common pathogens associated with dental abscesses. He also argued that the dosage he prescribed was within the recommended therapeutic range, and there was no reason to suspect antibiotic resistance. Post-surgical care and communication. Dr. Andrew insisted that he had maintained regular communication with the nursing staff regarding John's care. He noted that he had provided clear instructions for the post-surgical management of the abscess, including regular monitoring of the drainage and adjusting the antibiotics if necessary. Dr. Andrew argued that he could not be held responsible for what happened after he left for the conference, as the handover to his colleague had been conducted according to the hospital procedures. Decision not to escalate treatment. Finally, the maxillofacial surgeon, Dr. Andrew in this case, defended his decision not to escalate John's treatment earlier. He argued that John's condition had appeared to stabilize after the second incision, and there were no clear indications of a life-threatening complication until the day after the transfer. He emphasized that he had acted within the accepted standards of care for treating a dental abscess, and the unfortunate progression of John's infection was both rare and unpredictable. Dr. Andrews' defense was grounded in the argument that he followed standard medical protocols and that the complications John experienced were extremely uncommon. Let's move on to the findings of the disciplinary board after reviewing the case. The board reached the following conclusions. Number 1, failure to conduct a full physical examination. The board agreed with the plaintiffs that Dr. Andrew should have conducted a more thorough evaluation when John was first admitted. While the initial signs pointed to a localized infection, the board found that the severity of John's symptoms should have prompted further diagnostic testing, such as blood work or a CT scan, to rule out deeper infections. Inappropriate use of antibiotics. The board found that while amoxicillin is a standard first-line treatment for dental abscesses, Dr. Andrew should have considered switching to a broader spectrum antibiotic once it became clear that John's infection wasn't responding as expected. The board noted that the delay in receiving the bacterial culture results did not excuse the failure to adjust the antibiotic regimen based on John's clinical deterioration. Number 3. Inadequate post-surgical care and communication. The board found that Dr. Andrews' communication with the nursing staff was insufficient. They highlighted several instances in the medical records where important observations, such as John's persistent fever, were not properly escalated to Dr. Andrew. The board concluded that more active oversight was necessary, particularly given the severity of John's condition. Number 4. Failure to escalate treatment. Finally, the board determined that Dr. Andrew should have escalated John's care by consulting with other specialists. The board emphasized that infections in the head and neck region can lead to life-threatening complications, and more aggressive treatment should have been initiated earlier. Final ruling. The board ruled that the complaint was partially valid and issued a formal warning to Dr. Andrew. While they acknowledged that some aspects of the care provided were reasonable, they concluded that the failure to conduct thorough diagnostics and escalate treatment constituted a breach of professional responsibility. Let's take a few moments to break down some key medical terms from today's case. Dental abscess. This is a localized collection of pus caused by a bacterial infection. Abscesses in the mouth often follow dental procedures such as extractions and can become life-threatening if the infection spreads to surrounding tissues. Amoxicillin. This is a common antibiotic used to treat a variety of bacterial infections. It's often prescribed for dental infections but may need to be adjusted if the infection doesn't respond as expected. Incision and drainage. This is a surgical procedure used to treat abscesses by cutting into the infected area and allowing the pus to drain. It's a standard treatment for oral infections. Now, these terms help provide context to the medical decisions made in this case and why certain steps were taken or not taken by Dr. Andrew. As I close this episode, here are 2 questions I'd like to have you think about. Number 1, how should medical professionals balance protocol with individualized patient care when treating infections? So, while protocols provide a framework for treatment, doctors must always be prepared to adjust their approach based on the patient's response to treatment. When a patient's condition doesn't improve, more aggressive diagnostics or treatment adjustments should be considered, even if it goes beyond standard protocol. Question number 2, what role does communication play in ensuring patient safety, especially in hospital settings? Clear and consistent communication between doctors and nursing staff is essential. Without proper communication, critical signs of deterioration can be missed, leading to delays in treatment and potentially serious outcomes. Regular updates and clear instructions are key to maintaining a high standard of care. Thanks again for listening. If you enjoyed today's episode, be sure to subscribe and tune in for more Doctors in Court cases on the MI Mental podcast. Until next time.